So today's topic is malabsorption syndromes. Okay, what is malabsorption? Basically, it is a long topic. I have tried to concise it, and we will deal basically with three diseases which are of importance to medicine. Malabsorption syndrome, the definition, it is a state arising from the abnormality in the absorption of food nutrients across the GIT. Okay, basically, it is the abnormal absorption of nutrients across the gastrointestinal tract. Impairment can be of single or a multiple nutrients depending upon the abnormality, and this may lead to malnutrition and a variety of anemias. Okay. Malabsorption constitutes the pathological interference with the normal physiological sequence of the body, such as digestion, which is an intranuclear process. Then second thing is absorption, which is a mucosal process, and transport, which is a post-mucosal event of the nutrients. So basically the absorption occur in three parts. First, there is a digestion of food, which is there is digestion, which is intraluminal process. Then second, there is absorption, which is a mucosal process, and third is a transport, which is a post mucosal events. So basically anything which interferes with the absorption of nutrients across the GIT is considered to be malabsorption. Okay, now what is the normal physiological process of the absorption? It consists of three processes. First is digestion, which occurs in the lumen of the intestine. Then second is the absorption process, which occurs through the mucosa of the intestine. And third is the transport through the lymphatics and the blood vessels. Now, causes of malabsorption. The causes of malabsorption can be divided as digestive failure caused by the enzyme deficiency, structural defects, mucosal abnormalities can be caused by infective agents, and systemic diseases affecting GIT. So there could be a digestive failure due to various enzymes deficiencies, such as in chronic pancreatitis we have various deficiencies of pancreatic enzymes. Then there could be structural defects in the form of Crohn's disease, IBD. Then there can be a mucosal abnormality such as in the celiac diseases. Then there can be a infective agents such as tropical sprue and Whipple's diseases, and there can be systemic diseases which could be affecting GIT. तो अटेंडेंट को बुलाना, उसको अटेंडेंट होगा ना आउटसाइड, उसको बुलाना. Now, the causes according to the digestive failure. There could be pancreatic insufficiencies or there could be bile salts deficiencies. Now, pancreatic insufficiencies will be more related to what? Fat and protein digestion, while bile salts insufficiencies will result in fat digestion, abnormalities in the fat digestion. So there could, in pancreatic insufficiencies, we have cystic fibrosis, chronic pancreatitis, carcinoma of pancreas. Then bile salt insufficiency, we have obstructive jaundice and bacterial overgrowth syndromes. Then due to the structural defects such as IBDs in Crohn's, then gastrectomy and gastrojejunostomy due to post-surgery, then fistulae, diverticulas and structurals, which are again the structural defects, infiltrative conditions such as amyloidosis and lymphoma. Then we have short bowel syndrome, again this is post-surgery, and eosinophilic gastropathy. Then due to mucosal abnormalities, we have celiac diseases due to enzyme deficiencies, lactase deficiency causing lactose intolerance, disaccharides deficiency, entropeptidase deficiencies. So whenever you deal with a patient of malabsorption syndromes or a patient of IBD, you have to rule out all these causes before labeling the patient as irritable bowel syndrome. Okay, malabsorptions are important DDs of irritable bowel syndromes. Okay, then we have due to infective agents, Whipple's disease, intestinal TBs, tropical sprue, parasites such as Giardia lamblia. Then we have due to other systemic diseases affecting GI tract, that is hypo and hyperthyroidism. ये निकल के इसको Then we have diabetes, hyperparathyroidism and hypoparathyroidism, carcinoid syndromes and malnutrition. Then symptoms of malabsorption. Symptoms of malabsorption can be extraintestinal and intraintestinal. Most common symptom is diarrhea, mainly steatorrhea, which is the most common feature. It is due to the impaired carbohydrate, electrolyte, water absorption. Other symptoms will include all the features of nutrient deficiency, that is weight loss, growth retardation, swelling or edema, anemia, muscle cramps and bleeding tendencies. Okay, so basically the symptoms will pertain to the loss of the nutrient which is due to malabsorption. If there is a deficiency of iron, there will be features of anemia. If there is deficiency of fats, then there will be features of steatorrhea, like that only. Basically, from the medicinal point of view, I will deal with three things. Okay, celiac disease, tropical sprue and Whipple's disease. So everybody understood what malabsorption is. Basically is an impaired absorption of nutrients through the GI tract. Now what is a normal physiological process? There are three parts. All of you have understood that. Then causes can be divided according to the site, okay, where the malabsorption is occurring. Then celiac disease. It is an autoimmune disease where the immune system reacts abnormally to the gluten, causing inflamed and flattened villi. Basically it is considered to be a although the exact pathophysiology is still debatable, but it is considered to be autoimmune disease where immune system reacts abnormally to the gluten, causing inflamed and flattened villi. As you can see, this is a normal healthy villi and this is the villi in the celiac disease which has been damaged or has been flattened. Etiology, it is not known, but it is considered that it could be environmental, immunological and genetic factors which act as trigger to autoimmunity and contribute to the disease. So there are environmental factors, immunological and genetic factors. Now what are environmental factors? The environmental factors basically include gluten, hypersensitivity to gluten containing food materials. Then immunological serum antibodies such as IgA anti-gliadin, IgA anti-endomysial and IgA anti-DTG are present in these cases. However, it is not known whether these antibodies are primary or secondary to the tissue damage. Okay, so their exact role is still debatable. Then we have genetic factors. We have HLA-DQ2 allele in majority of the cases, and sorry, this is a misprint, HLA-D8 allele in minority, but 5% patients do not express any of these alleles. Celiac disease varies widely in different population groups, high in Caucasians, low in blacks and Asians. So basically celiac disease is a disease of Europeans. Okay, basically celiac disease is a disease of European. Pathophysiology, there is a partial villus atrophy in mild lesions of small intestinal lining. There is a subtotal or total villus atrophy in severe lesions of the small intestinal lining, forming the flat mucosa due to more advanced villus fusion, particularly in the upper jejunum. So site of injury is upper jejunum, where there is atrophy of the villi leading to flattened villi, leading to decreased absorption of food materials. Now, surface epithelial cells are cuboid or low columnar type. Lamina propria shows increased number of plasma cells and lymphocytes. Clinical features. How will the patient present to you? The patient will present to you with mild abdominal pain, bloating, steatorrhea, anemia of chronic disease, episodes of mild diarrhea or constipation, loss of appetite, weight loss, tingling or numbness in your hands and feet, vomiting, usually only affects the children, and alopecia usually only affects the adults, and malnutrition. So patient will come to you in the OPD typically with abdominal pain, bloating sensation, steatorrhea and anemia. These are the classical features of celiac disease. Investigation. You will, if you are suspecting a malabsorption syndrome, when do we suspect malabsorptions? Malabsorption syndrome are usually suspected in the patients where patient is having anemia, you cannot find the cause of the anemia. The patient is having iron deficiency anemia or B12 deficiency anemias, and you cannot find the cause of anemia. Then only you suspect the malabsorption syndrome. Okay. So whenever you suspect the malabsorption syndrome, patients are having such history, go for a blood test, anti-TTG, positive TTG serology, low levels of vitamin A, B12, E, D and K will be found. Okay. Then for gold standard for diagnosis is small intestinal biopsy, and in examinations too you will get steatoria. Now, if you do a endoscopy in cases of celiac disease, what will you get? Usually the duodenum appears normal, but some patients showing scalloping of the small bowel folds, paucity in the folds, cracked mud appearance of the mucosa. As you can see in this picture, you have a cracked mud appearance of the mucosa. This is classical. Then there is a prominence of some mucosa, blood vessels and nodular pattern of the mucosa. Now management. Diet. Patient has to be kept on lifelong gluten-free diet. Okay. The primary part of the management of the celiac disease is gluten-free diet for whole life. You need to send the patient to a dietitian who will advise him with the diet charts what foods he needs to avoid throughout his life so that he doesn't have a problem. Then steroids and immunosuppressants have been tried, such as azathioprine. This is only for refractory diseases where they do not improve on gluten-free diet. Most of the patients improve on gluten-free diet. Steroids and immunosuppressants are only reserved for the patients who do not improve on gluten-free diet. Then we come to the tropical sprue. Definition. It is a malabsorption syndrome disease commonly found in the tropical regions, marked with abnormal flattening of the villi and inflammation of small intestinal lining. Okay. So there is flattening of villi like the celiac disease, and there is a small inflammation of the small intestine. And there is a presence of infection. In celiac disease, you will not find the presence of infection. Okay. Etiology. The etiology and pathogenesis are uncertain. Why? Its occurrence is not evenly distributed even in the tropical areas. So, even in India, you will not find tropical sprue in northern India. It is mainly considered to be a disease of southern India. It is found in specific locations such as southern India, Philippines, several Caribbean islands, rarely observed in Africa, Jamaica, and Southeast Asia. Okay, so it is interspersed in between the countries. Even in India, you will not find the tropical sprue in whole of the Indian population. It is considered to be a disease of South Indian population only. An occasional individual will not develop symptoms of tropical sprue until long after having left an endemic area. So, it is not like that a patient who has been visiting South India recently will develop the symptoms of malabsorption or tropical sprue. It will be taking a long time before he develops the symptoms. So it can be not exactly correlated. Then multiple microorganisms have been identified on the jejunal aspirate with a relatively little consistency among the studies. So multiple or microorganisms have been found out, but there is not consistency between the research studies. But other studies have favored the role of a toxin produced by one or more of these bacteria, such as Klebsiella pneumoniae, Enterobacter cocci, or E. coli. Now, clinical features. Again, the clinical features of most malabsorption syndrome align, that is diarrhea, fatigue, weight loss, abdominal cramps, flatulence, and features of malnutrition. So, the basic symptoms are the same. Investigation. On a small intestinal biopsy, there will be less villous architectural alteration and more mononuclear cell infiltrate in the lamina propria. However, this resembles the celiac disease. There is flattening of the villi. there is mononuclear cell infiltrate, that is plasma cell and lymphoid cells will be present. How the way to differentiate these two is by having a gluten-free diet, and will not give a clinical or a histological improvement. So only way to differentiate between the two is you put the patient on the gluten-free diet, and when the patient does not improve, you can suspect that it is some other etiology, and that could be tropical sprue. Endoscopy, abnormal flattening of the villi and inflammation of the lining of the small intestine can be observed. The blood test, low levels of vitamin A, B12, E, D, K, as well as serum albumin and calcium and folate can be seen. Again, the examination of stool will reveal steatorrhea. Now, drug of choice to treat the tropical sprue is tetracycline or cotrimoxazole, given for 3 to 6 months, and along with it you will need vitamin B12 and folic acid as a supplement. Okay, so as you can see, before the treatment it is a flattened villi with lymphoid aggregates, and after treatment with doxycycline and folic acid therapy, you can see the normal villi has returned. So tropical sprue is basically a treatable condition, while celiac disease is not a treatable condition. Okay, then we have the Crohn's disease. It is an inflammatory bowel disease. We will deal it in with it in next lecture. It is marked by patchy areas of inflammation anywhere in the GIT from mouth to anus, and body's immune system, where the body's immune system attacks the GIT, leading to chronic inflammation. Then we have short bowel syndromes following the resection. Diarrhea or steatorrhea can appear due to decrease in the absorptive surface area of the intestine. Okay, whenever the patient undergoes intestinal resection due to any cause, okay, due to any cause, if the patient is due to peritonitis or due to mesenteric artery thrombosis, the patient has been resected a large amount of bowel, small intestine, then they usually develop the symptoms of short bowel syndromes. The symptoms again include cramping, bloating, and heartburns, but here you will have a history of surgery. Then we have bacterial overgrowth syndromes. There is proliferation of colonic type bacteria within the small intestine due to stasis caused by impaired peristalsis. This leads to diarrhea and malabsorption. Here the colonic bacteria moves up and there is an overgrowth in the small intestine. Then we have pathophysiology. The bacterial overgrowth leads to the metabolization of bile salts, resulting in deconjugation of bile salts. Okay, these bacteria deconjugate the bile salts, and so they will be metabolized, and there will be less amount of bile salts for the absorption of fat. So there will be a malabsorption of fat. Damage to the intestinal villi can be due to bacterial invasions, toxin production, metabolic products, and these damaged villi will cause total villus atrophy. So, Whipple's disease. This is the third and important disease from malabsorption point of view. Okay, Whipple's disease. So, what is the history behind Whipple's disease? In 1907, George H. Whipple described a 36-year-old clinician with a gradual loss of weight and strength, stools consisting chiefly of neutral fat and fatty acids, the indefinite abdominal signs, and a peculiar multiple arthritis. The patient died of this progressive illness. Whipple called it intestinal lipoid dystrophy, since he observed the accumulation of large masses of neutral fats and fatty acids in the lymph spaces. It was renamed as Whipple's disease in 1949 about the description of the sine qua non of this disorder: accumulation of macrophages in the lamina propria with intensely periodic acid shift pass positive intracellular material. An infectious etiology was suspected as early as Whipple's initial report. However, the successful treatment with antibiotic was not reported until 1952. So the first case was reported by George H. Whipple in 1907, where a doctor himself suffered from this disease, He was having a history of weight loss. He was having a history of steatorrhea. He was having abdominal signs. And third thing which was important, which he was having, was arthritis. Okay. So the first case was described by George Whipple. Okay. Then until late in 1949, ultimately the diagnosis of Whipple's disease was done through multiple case reports, and the name was given to honor the physician George H. Whipple, where on biopsies they found out that there was an accumulation of macrophages in the lamina propria with past positive intracellular material. An infectious etiology was suspected, and although in 1949 the infectious etiology was suspected, it was not until 1952 a organism was found, and ultimately it was treated by the use of antibiotics. Okay. Now, what is the organism responsible for Whipple's disease? It is the Triphonema whippleyi. Okay, it is a gram-positive bacillus related to Actinomycetes family. It is non-acid fast, past positive, with characteristic trilaminar plasma membrane surrounded by a cell wall. So, what is diagnostic of Whipple's disease? The main diagnostic feature of Whipple's disease is the presence of past positive macrophages along with the presence of Triphonema whippleyi, which is recognized by trilaminar plasma membrane. Okay, presence of this plasma membrane in the biopsy samples is important to diagnose Triphonema whippleyi. Although we have PCRs to diagnose this disease right now, but a mere presence of a PCR positive study does not give us the confirmed diagnosis of Whipple's disease. Within the submucosa and macrophages of the patient. Now, pathogenesis. The route of invasion is via the lamina propria. There is accumulation of massive number of organisms within the tract. However, the patient with Whipple's disease do not appear to be prone to opportunistic infections or malignancies. Clinical features. The classical features of Whipple's are joint symptoms, first and foremost, then chronic diarrhea, malabsorption, and weight loss. But many other organ systems can be affected. It is a multi-system disease. It is not just limited to the joints and GIT. What other organ systems are affected in Whipple's? Anyone? We have seen celiac disease. We have seen tropical sprue. Basically, all the symptoms are limited to the GI tract. No extra intestinal manifestations are there. But in Whipple's, you have extra intestinal manifestations. Basically, CNS can be involved. Then cardiac system can be involved. Then pulmonary can be involved. Dermatological system can be involved. Okay. So it is a multi-system disorder. Although the patient presents to you characteristically with these 4 symptoms. Lymphadenopathy predominantly of the mesenteric and mediastinal lymph node, but it is not considered to be a diagnostic because it can be present in multiple other diseases such as intestinal tuberculosis also. Dementia and other central nervous system findings such as supranuclear ophthalmoplegia, nystagmus and myoclonus can be present. Then if we look at the cardiac system, then we have the endocarditis, pericarditis and myocarditis can be there. Then we have pleuropulmonary disease including pleural effusion, chronic cough, ILD-like presentation and pulmonary hypertension. Okay. Then there can be a skin hyperpigmentation. Now GI symptoms. GI symptoms, patient will present to you with intermittent diarrhea and colicky abdominal pain, watery diarrhea and steatorrhea, occult and gross GI bleed, okay, and severe wasting syndrome and weight loss. So important thing in GI system, what is included in Whipple's, which is not included in celiac and tropical sprue, is GI bleed, okay. GI bleed can be present in Whipple's disease. It could be occult, it could be gross. Now, what you have to exclude before arriving at the diagnosis of Whipple's disease? Differentials, important differentials. Hyperthyroidism, connective tissue disorders, IBD and HIV. Okay, these are the important differentials or the diseases that you have to exclude before labeling the patient as Whipple's. Diagnosis: upper GI endoscopy with biopsies of small intestine for Trypanosoma whippleyi testing, for histology with PAS staining. Then we have PCR testing and immunohistochemistry. Now, these three diagnostic tests are available for the diagnosis of Whipple's disease. However, the gold standard is biopsy with PAS positive staining. If a small bowel biopsies are not diagnostic, but the suspicion for Whipple's disease remains, or if the patient initially presents with extraintestinal symptoms, other tissue or fluid specimens can be obtained for Trypanosoma whippleyi testing. If you have other systems involved and you are not getting diagnostic result with intestinal biopsies, then you can obviously again test the fluids or samples from the other systems. Then we have our diagnostic criteria. The diagnosis of Whipple's disease can be made with classical finding of PAS positive macrophages from small bowel biopsy. As I previously told you, it is the presence of PAS positive macrophages from a small intestinal biopsy that is the gold standard for diagnosis of Whipple's. The absence of this in the absence of this finding, the diagnosis can also be made when two different Trypanosoma whippleyi tests such as PAS, PCR or immunohistochemistry from the same specimen is positive. Matlab, you should have at least two tests positive from the same sample, or two tests from different specimens are positive. The example with positive PAS staining and PCR from a synovial sample, or positive PCR from both small bowel biopsy and a synovial sample. Okay. Now, how do you treat Whipple's disease? Earlier, the drug of choice was what? Earlier, what was used to treat Whipple's? This is the new treatment modality. Earlier, they used to use tetracycline for the treatment of Whipple's, but it had a high relapse rate. 35% of the cases had relapse. Okay, so it was abandoned, and now we use ceftriaxone 2 gram IV once daily, or penicillin 2 billion units IV every 4 hours for 2 weeks. Okay, this is the induction phase of the treatment. You need to use ceftriaxone or penicillin for 14 days at least, followed by cotrimoxazole double strength twice a day for 1 year. Okay, so in induction phase you will use either penicillin or ceftriaxone, and for maintenance phase you will use Ceftran double strength BD for 1 year. Now, how do you manage malabsorption syndrome? You need to replace the nutrients, electrolytes and fluids if necessary. In the severe deficiency, hospital admission may be required for parenteral administration of these nutrients. Pancreatic enzymes such as in chronic pancreatitis are supplemented orally in the form of pancreatic insufficiency. Then dietary modifications is important in some conditions, that is the gluten-free diet in celiac disease, lactulose avoidance in lactase deficiencies. Then we have antibiotic therapy to treat small bowel bacteria overgrowth. So, in short, you know what is malabsorption, what is the process of absorption, what are the causes of malabsorption. Okay, from the medicine point of view, need to know about these three conditions, which are basically celiac disease, tropical sprue, and Whipple's disease. Celiac disease and tropical sprue are almost similar. They have similar features. One is having an infectious etiology and other is a autoimmune process. Okay, the findings on histology are basically same in the both. Okay, then you have the Whipple's disease, which again presents with you along with malabsorption features with the joint symptoms. Okay, it is a multi-system disorder. It can involve the other systems also, that is the CNS, cardiac, pulmonary, as well as skin. Okay, again the treatment regimes are different. For celiac disease, you need to keep the patient on a gluten-free diet, while for the tropical sprue, you need to use antibiotics, again Septran. Then for the Whipple's disease, you need to give a combination of ceftriaxone and Septran, and the treatment should last for at least 1 year. Okay, so from Indian point of view, tropical sprue is the most important. Okay, in which of the following scenarios should celiac disease be strongly considered? The patient has coexisting anorexia or bulimia. The patient has iron deficiency but no apparent GI bleeding. The patient has known lactose intolerance. The patient has a chronic diarrhea but claims to be able to tolerate gluten-rich food. Yes. You basically suspect the malabsorption when you are not able to find the cause for nutrient deficiencies and the patient is having other GI symptoms also. Which diagnostics test for celiac disease has sensitivity and specificity greater than 90%? Anti-tissue transglutaminase antibody or AGA, protein malabsorption suggested by hypoproteinemia and hypoalbuminemia, human leukocyte antigen HLA-DQ2 and DQ8 test, and small biopsy from the second portion of the duodenum. Answer is A. Anti-tissue transglutaminase antibody, anti-TTG. Although it has a specificity of more than 90%, but it is not gold standard. Gold standard are only the endoscopy guided small intestinal biopsies. Okay. What is the underlying cause of diarrhea and abdominal discomfort in patients with celiac disease? Intestinal obstruction, incomplete digestion, malabsorption, and or irritable bowel disease. Malabsorption. It is the malabsorption. Whipple's disease primarily affects the men aged 30 to 60 and is associated with subtle cell-mediated immunity defect, increasing susceptibility to Treponema whippleyi infection. Approximately what percentage of patients with Whipple's disease test positive for HLA-B27? It is a cross diagnosis. What percentage test positive for HLA-B27? HLA-B27 can be positive in multiple conditions. Okay. So we don't specifically use it as a gold standard diagnostic tool. You all know in ankylosing spondylitis also, unless and until the patient is having a clinical feature which are supporting the diagnosis of ankylosing spondylitis only with the positivity of HLA-B27, we don't consider the patient to be positive for ankylosing spondylitis. Similarly, in Whipple's disease, HLA-B27 can be positive in about 30% of the cases, but still we don't consider the diagnosis of Whipple's disease unless and until other symptoms are corroborative to it. Which symptoms of Whipple's disease typically appear first, depending on the affected organ systems? Weight loss, arthritis and fever, diarrhea, increased skin pigmentation. Arthritis and diarrhea. Joint symptoms are the first symptoms to appear before the malabsorption. So, Whipple's disease, you need to keep in mind before keeping the diagnosis of Whipple's disease that the joint symptoms will be the first to appear in the patient. Okay. Untreated Whipple's disease can be progressive and fatal, but with many antibiotics which are curative, which antibiotic is the most appropriate for initial treatment? Ampicillin, ceftriaxone, HCQ, Ceftriaxone. It is the ceftriaxone. So in nutshell, if anybody can tell me what are the symptoms of malabsorption? What are the symptoms of malabsorption? Malabsorption can be a very confusing topic. Okay. And it could be a easiest topic. You have to just summarize and you have to know the differences. How will the patient in OPD present to you? The patient will present to you with abdominal pain, bloating, diarrhea, specifically steatorrhea. Okay. Then he will present to you with symptoms of deficiencies such as most commonly iron and B12 deficiencies will be there in those patients. That is why malabsorption syndromes are the most important differentials of IBS. Before labeling the patient as IBS, you need to exclude the malabsorption, because most of the patients of malabsorption syndrome are initially treated as IBS because nobody can find the cause. Okay, so they get for a long time treated as IBS in the OPDs. So they are the important differentials of IBS. Okay, so you need to exclude them, and it is very simple to exclude them. You need to get a stool examination. If there is steatorrhea, there is a malabsorption. Okay, if you are suspecting gluten hypersensitivity, then you need to put a patient on the gluten-free diet. If it is a celiac disease, he will respond. If it is not a celiac disease, you can suspect tropical sprue. If the patient is presenting to you with the joint features initially before the malabsorption, then you can suspect the Whipple's. Okay, so it is just that you should know the features and you should know how to differentiate between these. Okay. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 63, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 20, 21, roll number 20, 30, 95,